Good afternoon, everyone. It's a big honor for me to read out the citation of Professor Sam G.P. Moses' oration citation, honoring Padma Shri Professor V. Seshaya oration citation. DAI Southern Chapter takes immense pressure in conferring the Professor Sam G.P. oration upon Padma Shri Professor V. Seshaya, a visionary leader, pioneer researcher, and a stalwart in the field of diabetology. Professor Seshaya, Honorary Distinguished Professor of the Tamil Nadu Dr. MGR Medical University for Life, has devoted over 5 decades to advancing the science and practice of diabetes care in India. Following his service in the Indian Army, where he was decorated with the Samar Seva Star and Sainya Seva Medal with clasp Himalayas, he joined the Madras Medical College as Assistant Professor of Medicine. With foresight and determination, he established in 1978 the first Department of Diabetology in India at Madras Medical College. And in 1980, founded the Diabetes in Pregnancy Division at the Institute of Obstetrics and Gynecology, Government Maternity Hospital, Egmore. Impaired and mentored by the legendary Professor Sam G.P. Moses, he pioneered the field of gestational diabetes mellitus in India. He authored the first monograph on GDM in 1982, and through decades of dedicated research, simplified diagnostic testing with a simple single-step procedure, now globally recognized by WHO, FIGO, and IDF. His vision led to the founding of Diabetes in Pregnancy Study Group India, DIPSI, which has shaped national and international guidelines and made universal screening for GDM a reality even in resource-limited settings. A passionate teacher and institution builder, Professor Seshaya initiated the country's first diploma course in diabetology, nurturing generations of diabetologists. His relentless focus on maternal health has transformed outcomes for countless mothers and newborns, encapsulated in his enduring message, "Women's health is nation's wealth." For his monumental contribution, Professor Seshaya has been honored with the B.C. Roy National Award in 1988, the International Diabetes Federation Lifetime Achievement Award in 2017, and the Padma Shri in Medicine in 2022, and the prestigious Hippocrates Award 2024, among many others. His pioneering work continues with a vision of a diabetes-free generation through primordial prevention strategies focusing on maternal health. In recognition of his lifetime of service, his groundbreaking contributions to diabetology and diabetes in pregnancy, and his transformative vision for a healthier future, Diabetes Association of India, Southern Chapter, is privileged to confer upon Padma Shri Professor V. Seshaya the Professor Sam G.P. Moses oration with deepest respect, heartfelt gratitude, and warm congratulations.
Thank you, sir. Now, I would like to welcome our Professor Lakshmi Narayanan, sir, to deliver the citation to Professor Sam G.P. Motion oration delivered by V. Seshaya and the citation delivered by Narasimhan, sir. Lakshmi Narayanan, sir. Professor Ariran, sir, to present the medal to Professor V. Seshaya, sir. Professor Madhavan, sir, please, to give the shield to Professor Seshaya, sir.
Thank the organizing committee for giving me the privilege of sharing Professor Seshaya's oration today. named after Professor Sam G.P. Moses. Now, I've been with him for well over 40 years, but I think this is the first time I'm here as a chairperson for you. And all of us have just celebrated, the country has celebrated Teachers' Day yesterday, and we are today here to celebrate the teacher of teachers in the field of diabetology here. And as Dr. Rajendran made a mention about Guru, I think we start with saying Guru Bhyo Namaha. I think that is a salutation that we give to our teachers. Now, enough has been said in the introductory remarks as well as in the citation, but beyond his academic achievements, what we all cherish is the brotherhood that he has nurtured in the Department of Diabetology ever since the department was started. When Dr. Sundaram was the first assistant, I joined him subsequently. And in the book written by Dr. Sundaram, Sarkarai Mani, you should have seen the foreword what he wrote. Professor Sam G.P. Moses is my munnodi, and Sundaram and Hariharan are my pinnodigal. I don't know whether such term exists in Tamil, but he could introduce even a new terminology for what he thought in his mind. And true to the tradition of Dr. Sam G.P. Moses, with whom he was affectionately associated, Dr. Moses sowed the seeds for diabetology in this country, and it was up to Dr. Seshaya to nurture and bring it up to the extent that it is today. There were hardly 3 or 4 diabetologists in Tamil Nadu at that time. I am talking about the 70s. And now you turn to every nook and corner, you have diabetologists. And that is all largely due to the effort that he has made over the years. As was mentioned, he started the course and he inducted many people into the specialty and saw to it that they all come up in life. Contrary to what used to be practiced prior to 1970s, no chief liked the assistant to be good. But it was Dr. Moses and Dr. Seshaya liked their students and assistants to be good and upcoming. And as in the words of Dr. Moses, he always used to say, I want my students to be good because when I become sick, I must have an intelligent student who can treat me. No, I do not, because most of you may not know what was in existence in the medical profession in the 60s and 70s, when I have seen professors who see a practitioner, his assistant practicing in a clinic, he will simply pass by and ask him, give him some orders to do something in the evening so that he cannot practice. Now, that was the time in the 60s and 70s. Now, we've all come up only because of him. What we are today, each and every one of us who is here, if we are holding our head high in the society, it is largely because of his contribution to all of us. As for his interest in diabetology in general and pregnancy diabetes in particular, nothing is more important to state that at a time when obstetricians did not even agree to the concept of pregnancy and diabetes, I'm talking about 1979-80, when he went to the maternity hospital to start a pregnancy diabetic service there, he was curtly told by the then superintendent, we hardly see half a dozen cases of diabetes and pregnancy in a year. Why do we require such a service? Now, thanks to the efforts of Professor Moses and Dr. Seshaya, they could convince them more out of, their perseverance than because of the convincing attitude of the superintendent. It was started, and today, you know, now they have taken it over more than us. Obstetricians are much more particular about pregnancy and diabetes and abnormal glucose tolerance in pregnancy. Now, he had the knack of, they said that he served in the army, but he was a very good leader who was not that strict at the same time. He could get everything done out of the assistant with him. As Thiruvallur says, Idanai Idanal Ivan Mudikkum Endarundu Adanai Avan Kan Vidal. You can't get a better example than Professor Desai. He could get things done for the department. I know how difficult it is to mold the department and bring it up. That's what he did over the years there. And we've all been fortunate to have been with him and to stand close to him in the same podium and rub shoulders with him is an honor that one should cherish. Thank you very much, and I request you, sir, to deliver your talk for Professor Sam G.P. Moration on the topic of your choice, which is dear to his heart. Closest to his heart is diabetes and pregnancy, and he will tell us the Indian solutions to the Indian problems. Sir.
Thank you. Respected chairpersons, I'm calling you chairpersons today. My dear friends, my dear colleagues, my dear doctors here, I don't know what to call you. I'll call my children or what, I don't know. I tell one word here now, I just came to mind when you are talking now. Mata, Pita, Guru, Daivam. What do you do at the last? My Sishyas, Sundaram and Hariharan, first Sishyas, then all of you are here. So I have come up in my life because not only my parents, but also by support. From the beginning, I got support from Sundaram and as well as again we call Hariharan. I call Hari. Hari is a pet name, not only for you and for my son also. His name is Hari. Anyway, now coming to this topic now, I think you had a very, very scientific meeting we had. I am not going to that amount of seriousness of my talk. It will be easy to follow what I am going to speak here. I am going to speak on now this type of what is happening in the public now. In particular, as Hari told, I started working on the diabetes from the pregnancy because the reason I tell you now here. Now, it happened like the Moses, I became assistant. Then what happened, I also became professor 1979 in the Department of Diabetology. Of course, though I always held my professor as my, all the time from the day of started, he was with me, so it was very close to him. Then any conference I go, I will go along with him. And like that, I also went in 1979 to Vienna for a participant in the IDF conference there. At that time, it also happened then. You will see that as in 1979, Professor Moses, and this time I am sitting there, we were discussing what we are going to do, number of discussions we had, diabetes and heart, diabetes and nephrology, so many things went on. But somehow in his mind, he said, you don't have to take up diabetes and pregnancy as a specialty, though diabetology is there, you do this. Then from that day he said, now you go there. He wanted me to go to, this is where I went, very important place in the Scotland. From there, Vienna, I flew to Scotland, where Aberdeen Royal Infirmary, Scotland, is the largest hospital in that place, located on the Forstel site in Aberdeen. Is a teaching hospital with around 900 inpatient beds, offering tertiary care for a population of over 60 lakhs people across the north of Scotland. In them, Professor Stowers and Sutherland, the two professors, I went and met them, how they are working in that circumstances. So where the pregnancy service, where diabetologists and obstetricians sit together and decide the management. You will imagine now, those days, about 1980, those years, we don't know what happened in the Obstetric and Gynecology Institute. They also don't know what is our Madras Medical College. So patients, something happened in the OB/GYN, they'll call the assistant professor to come and see like that. It's always OP never done like that. So after this is the place where obstetrician and physician sit together. It's very unique and see the patient and help them how to go about that. So we came back from the Aberdeen straight away and immediately I started the clinic in the Institute of Obstetric Gynecology. But that time, for Mrs. Phillips, professor of obstetric and gynecology, superintendent, my teacher, Professor Moses. Then Dr. Balram was very helpful to me in those days, and Dr. Jagadishan, Subbulakshmi Jagadishan was the minister. I think not health, somehow Balram knows him very well, so he came to the hospital, inaugurated the center that is called Feto. This is very unique. I don't think anywhere in the world this will be there except Scotland. Feto Placental Maternal Unit was started in 1980 by all those people I given the name here. Now coming back, my Hariharan Sundaram was sitting here. That is the time this was made. Within 2 years, we are able to bring effects and control of glucose intolerance on feto-placental maternal unit. Again, this is a very unique name it is. This was 1982. 1980, I went to Scotland, came back within 2 years with the help of my colleagues there. This was presented in IDF in Nairobi, 1982. Within 2 years, I will do that. You see on the right side, that white background, all these things will be there. Professor Moses will be there, Professor Mir there, Professor Sundaram, Hariharan, Dr. Ram Kumar, Srinivasan, Anjalakshi, and also Moni Bansal. So many people together, both physicians as well as obstetricians. Now from there I went to another person here in my life. This humble book prompted to show him to the Nairobi. He was so impressed. See, that is such a booklet, not printed. It's only cyclostyle. I think that fellow was there. What is his name? Srinivasan. That book only we went there. That they saw that he was so impressed. He came to Chennai. He came to our department to see what is happening. It's called Professor J.J. Hood, President of the International Diabetes Federation, to visit our institute. He was so impressed because the first time from India, small booklet was shared in the International Diabetes Federation conference. So he was impressed. He came. Anyway, that so far went on. Now we go here. From feto-placental maternal unit, which we found people not able to say that name, so we want to call it just like that, diabetes and pregnancy unit. So now coming back to my talk here, gestation diabetes mellitus here called GD may play a crucial role in increasing prevalence of diabetes and obesity. That is another biggest problem. And for them, what could happen here, the problem is these particular people, insulin resistance, increased atherogenic lipoprofile, inflammatory markers, hypertension, and endothelial disease, all these complications will occur in the woman when during the pregnancy. That is what GDM is a very, very problematic situation here. That is time I coined the word. GDM is the mother of non-communicable diseases. So that is how I was so interested in work on the period of in pregnancy as a GDM. Now, this is another thing you will be here. Gestational diabetes, what could happen? The long-term complication of the mother on the left side, type 2 diabetes, cardiovascular disease. Imagine this could happen. Obesity, ophthalmic disease, renal disease, all these things, long-term complications will occur in the long term. Now, when you come to short-term complications in the pregnancy GDM, preeclampsia, eclampsia, prolonged labor, dysphagia, the cesarean delivery, surgical complications, postpartum, all these complications will occur. And comes to long-term complications, glucose intolerance, that is diabetes, obesity, endocrine morbidity, cardiovascular morbidity, neuroprotective developmental outcome, neuropsychiatric morbidity, ophthalmic diseases, short-term complications to the offspring, like the fetal microsomia, shoulder dystocia, collaborative dysfunction, brachial plexus injury, and also. Now tell me, which one should we take as priority? See, whole thing in the world, this is what is happening to GDM and its complications. So much a problem would happen here, and now we will have diabetologists will be there, endocrinologists will be there, cardiologists will be there. Everybody has to know what is happening here, because responsible will be here. 44% of all death in the worldwide is due to the GDM. That is what is paining us. Now, not only the effect of hyperglycemia on the fetus, Gestational diabetic mother's hyperglycemia goes to fetal hyperglycemia. Placenta, it goes to impaired glucose tolerance in the infant, and the mother's insulin doesn't go to the child, but in the macrosomia occurs because of the hyperglycemia. Sugar goes to the placenta. That is what told maternal statement here. Maternal hyperglycemia and progeny. The offspring of who were in utero, when their mother, this is a very important statement. The offspring of who were in the utero, when their mother had gestational diabetes, have a greater risk of developing diabetes again. Not only that, then earlier siblings born before the mother developed GDM. So intrauterine milieu goes to innate heredity, that is what called hyperglycemic pregnancy. Here again I must state here my mentor message. This is always quote: maternal hyperglycemia and fetal hyperinsulinemia are the kingpins of maternal metabolism. That is what told my mantra from Professor Sanjay Moses. This cannot be forgotten. Now we go to here now. Then what happened? We went to start there. Then what was happening? If you look at this here, Sullivan Mahan, I don't know how many OBGYN here. Sullivan Mahan, 1964, they do the test. How can this 90, such a huge number, 4 times you must do to diagnose GDM in the pregnancy. You imagine how to woman 4 blood tests. And next will be here, National Diabetic Group, NDDG, 1979. Again, same 4 times, number of times, value will be there. I don't want to repeat all those things because you may not be able to remember now. But I just want to tell here, Carpenter question, 1982. Then comes 2-step, again same thing. So you can imagine in the hospital, maternity hospital, how can I do all this test? Is there anyone's test? We cannot do. Where is the money? And if not possible. So that is why we did study with Hari, Sundaram and all, those times were there. We were working in the hospital. This is what we call spot test. That's what we introduced that time for glucose in pregnancy, whereas me, Hari, Sundaram, Ramar Kumar is not there. Ganesh also is available, he is not come here. Jyoti, Professor Sanjay Moses. This is the Department of Madras Medical College and Government General Hospital, India. It was done 1986, so early, almost 40 years now if you take it. At that time we came for the spot test. What does the spot test happen there? This is the first discovery, what you can't discover. Scientific work we can do it. This is what is 79 to all the year you will see so many women, 16,000 women coming to the OP department. How can I do the blood sugar level for them? 4 times. Fasting, 1 hour, half an hour, 1 hour or 2. Not possible at all. So 16,000 people have to do this GDM every year, which is not possible. So per year at the rate of 3 per subject will be almost 50,000 tests has to be done. Per day will be almost 140. That is what me and my colleagues were facing this situation. Then what we want to do, what we did will be here. And again, Dr. Sanjeev has come here. He is one other person who is from Sweden. So he knows what was happening at that time. So this is what happened there. It is a wonderful study. I was a little, Hari, I was wondering about this value of 110. I asked the statistician, that's why I put circles. That is what they said, 110 is supposed to be for the diagnosis of GDM came up there. That is statistician. Then again here you will see here, O11, I told you, it's gone. Nendedy gone, Carpenter gone, then finally Sachet came. This is called spot test. 1986 it was published. 1982 worked, published game 1980. It's only 2 steps, but still we did finally 110 as I told you, single value to diagnose GDM, 1 test will do at 2 hours, and there is no necessary glucose, just a meal, whatever meal, you say half an hour, like a number of times you do. But for number came here, 110. Now I tell you what is the importance of 110 in my future, what happened here. It was, remember this number, 1986, it was published. Then now come to another angle, evolution in the diagnosis of the hyperglycemia of pregnancy. What happened here? Again all those things I am repeating here. Now we come here. Then comes the spot test, 1986. Now lately there's one step test come here will be 2005, which is what you are doing will be the less than, this called DIPSI guidelines, less than 140. The value goes on. We want to come to a single value. Now finally, DIPSI single test is again come here, fasting and not fasting, made the life very simple to diagnose GDM. In this again comes to 140 milligram. So from where it was, now where it has come 140 milligram. Just remember this fellow. This DIPSI is also done by us. All over India it is being followed. Some people may follow IADPG, but I will tell you why it is not to be done. Now at present, and our colleagues, we are able to do the DIPSI guidelines or body to, and that is what happening in the country now, 140. Now here, IADPG is coming this value. Again, some of the OBGYN follow this also, but I don't think it's acceptable now. And finally, WHO also is coming there. This will be the concept early, this is final. From the DIPSI test, now finally, concept. This came to, fortunately in 2002, I was given Padma Shri Award. So after Padma Shri Award, I wanted to Padma Bhushan Award. When I am going to get Padma Bhushan? So I started working. So next year I will get it. Padma Bhushan. So because I went to this, because new thing, a new idea came, one Padma Shri. So concept, the year no glucose load, only single value, 2 postprandial, 110. That is the final concept which was given to all my colleagues here. That is what is happening. Now what next step I am going here, which gestational week, glucose tolerance to be screened. Now I told you 110, now I am going to come to further pointing towards which week, which time you will look into that. This is very important. Again, what happened all the time here, 24th week, 28th week, all those things was going on. Suddenly some development came here. This came treatment of GDM before 20th week gestation. This came treatment of this from the Australia group, Tobo Gym, this course. Here he told 20th week, 24th week mostly, then 28th week, then this fellow came down 20th week, but he did not tell which week, 20th week below. So he was not able to, if you look at the publication, you will say anything will be there. Now what we did, now next step, what I am going to say here, not only that Australian group, this group, if those who are Western group, American group, standard of care in diabetes, GDM should be screened for abnormal glucose tolerance, metabolism, less than 15th week. Nobody tells which week. Less than 15th week. They will say 10th week, the 12th week, they went for 15th week. That is 20th week. Then 20th week. What week I am going to do here, that is why I will discuss now. This is what happened. This is 2025, latest, as American guidelines. Now, after that, now we are still working on the glycemic level, distance weeks, prediction of GDM, at which week. Now, fortunately, we have come to this outcome study somewhere. First time National Institute of Health in 2018 suggested A1C 5.3, that is 2 postprandial, more 100 milligram at the 10th week, predict GDM. This was a mantra. That is the time which we came to know about that. 10th week. No, I picked up from the available data. Then what happened? Why the 10th week important? That is again I'm giving an example here. Embryology of beta cell. Why 10th week? That fellow told, and why you are going to prove it? Each islet cell functions as an endocrine organ. Every year endocrine organ. Here if you look at that, pancreatic islet cell differentiates 10th and 11th week of gestation. Pancreatic islet cell in the fetus. And that most important will be here, recognizes this is again very important for us in the future. As Dr. Venkataraman was telling beautifully so many things about the drugs for the obesity, like this also recognizes and responsible to maternal glycemia at 11th week of gestation. So that is the point, 11th week. So what is going to have 10th week and 11th week, what is going to happen now here? So we will decide future. Now all of us know about detection of GDM is possible by very diagnostic test. Something will be there, so many diagnostic tests, but what we got detection. Now again, prediction. If you look, it's not at which week at glycemic level, development of GDM. Okay, that is what we should know also, which week should I told you, but still I'm giving the evidence for that. And finally here, all things detection, prediction, and then will be prevention will be the measure to avoid the development of GDM and its consequences. That is almost I'm coming to the end of my talk. Consequence will be here, prevention is possible. Now what next step here? This slide is very, very important. This slide is not followed, other slides will find difficult to follow that. Now if you look at this, if in the country that time, 2022, ADA, ACO, so many guidelines are there. Which guidelines will you follow? You will follow an American guidelines, you want the Scotland guidelines, which one can follow? Now we will see here, you take IADPG, imagine here. What you will do? IADPG guidelines needs revision. As even at center that accepted recommendation, the approach varies, so that it is not to be followed. IADPG is not, Boyd Metzer himself says, I am not somebody, it's somebody. Now next thing what happened here, ADE and ACOG. If you go Delhi one guidelines, one comes to Chennai another guidelines, how can it happen? Same thing happened here. ADA is America, ACO is America, that what happened here? Different countries have different guidelines for the diagnosis of GDM, and even the same country has two guidelines which lead to confusion among the healthcare professionals. That is what's happening even in America. Some of ADA is followed by the endocrinologist, whereas ACOG is followed by the obstetricians. So how will you treat them, how will you diagnose them? That's what is still America, it is happening like that. So what I'm suggesting, don't follow that. Come to Chennai. Therefore, we are correct. The physiological glycemic level in normal pregnancy has to be recognized and implemented. That is very simple. If I know what is physiology and go into that. So the answer comes here. Pattern of glycemia in normal pregnancy is around about even up to 33 weeks it will be like that. So if you look at the picture here, fasting 71 plus or minus 8 and 2 over 99 plus or minus very important number. Finally, in pregnancy, 2 over blood sugar, 2 over less than 110 milligram. So what all the values have come now? Now we have come down to physiological 110 milligram. So that number you must always give 110 milligram pregnancy. This was done by, I will tell you who told you now. Any value above normal is abnormal. Hernandez. So conceptualization, endocrinology and nephrology both together, maternal to PPG should not cross 110 milligrams at 10th week as fetal beta cells start secreting insulin around the 11th week. So both are important. Maternal to should not cross 110 at 10th week, because if it continues like that, as I told long time ago, hyperglycemia, hyperinsulinemia by Professor Sam J. Moses, now it comes here, comes back. Yeah, maternal blood sugar of 110 at 10th week as fetal beta cells start secreting insulin around 11th week of pregnancy. So these both numbers very important. 10th number and 11th week number also. So now coming to final talk, early gestational glucose intolerance. That is called EGI. Intervention. That's what must intervene. Early gestational glucose intolerance. When it comes like that, the ideal is to try for the glucose tolerance at the 8th week. Why you want to do the test at the 8th week? Though I told it 10th week, why at the 8th week? Because anticipation here will be why. Prediction of GDM is store PPG is between 110 to 119. That's why more than 110 at 10th week. That I told you. Now our next step will be here. Hence, 8th week anticipation. Because answer the 8th week itself. Before getting married, you see the photo of your wife. I've seen people like that. Anyya? Panera Mahadev, she says, is Nera Patana. So what? Hence at the 8th week itself, tour people has to be estimated. You can't wait till 10th week. By the time, what will happen? So, if you listen to 110 milligram, follow up and monitor CBG. Okay, forget about that. Normally, you get married. Suppose now, in case tour PPG more than 110 milligrams, at the 8th week, a grace period of 2 weeks available. Suppose going to more than 110, still you can work it up. A grace period of 2 weeks is available at attain. Tour PPG has to be less than 110 at the 10th week with MNT nutrition or by the metformin. So, how I am bringing the two number? 110, 10th week. Again 110 and 8th week. 8th week, if we start working on that, it should not cross 110. That is value of telling this value of, you can do, MNT is more important. Now, finally here, 8th week, intervention at 10th week, less than a 10th, grace period of 2 weeks, and finally here will be more than 110 again will be no increase in fetal beta cell infusion secretion, and following up less than 10 weeks. If more than 110 milligrams at the 10th week, you cannot do anything. It's over. So, but very careful. So, not enough time is available to achieve less than 110 milligrams, and fetal beta cell secretion starts increasing. Now coming back to here, statement about this number, 110. Now this is very important slide, embryonic stage, because many people know whether to be given or not to given tablet, medicine. Embryonic stage will be up to 8th week. After 8th week, it will be a 0 to 2 weeks germinal. When it goes to 3 to 8th week, embryonic. When after the 8th week, it is going to be fetal. So that means all the organs are over by the 8th week. So from 8th, 9th week, it will be safer to use any drug. That's what happened here. If 110, MNT and metformin 250 mg has to be started and continued. Target glycemic is to be obtained in 2 or ppg. 99 the target, 99 plus 110. Metformin is safe. This is again confusion going on. People say yes or that. But anyway, you will see what happens. Metformin is safe and embryonic stage is over by 8th week. Metformin is safe for use throughout pregnancy. Conception of birth is possible. Now, the subject expert committee, I don't know who is that. Prakash is there, no? He is the man. He is the person. Who is the member? He is the member. The subject expert committee, he said, following the review, the subject expert committee has recommended the consideration of metformin 500 mg, whatever may be used during pregnancy at the treating physician's discretion as an adjunct or alternative to insulin therapy, 2025 November 24. Now this is at present we are this subject expert committee is approved. But I don't know who can give it, and it is going to, which official has to give. I have no anything known about that. This committee has approved, isn't it? Anyway, so okay. So, another final message for you, initiation of metformin after 12th week will not be effective in preventing GDM. This is very, very important. Once you don't treat by 10th or 11th week, everything is okay. After 11th week crosses, suppose comes 12th week, even if you load them with any tablet, that lady will not avoid GDM. She will become GDM. Even treat glucose comes there, it's still the child will become diabetic in the future. So that's why prevention of GDM is not possible here. So finally, the evidence medicine study come here. Group A, this is a theory of what had happened here. Finally, the detection and care of early gestational glucose intolerance, less than 110 milligram, prevents GDM, not only GDM, but also prevents diabetes and also prevents NCD in later years. So that shows the more important figure in this GDM will be 110 milligrams. Successful outcome of this study establishes that premortal preventive diabetes is possible if you treat with 110 milligrams. The methodology, of course, hemoglobin A1C is available, but we don't recommend that, not possible. Our population, the mean diagnosing level is not pregnant is not for monitoring. A simple point of care test with the glucometer. We don't want any lab. Lab, we can do it. It's not possible, not economical. You can use the glucometer. That's what we are following in all our studies. So finally, I am going to summing up now. Indispensable postmortem glycemia, indispensable. You must appreciate my work. That's why I told you, Artha Padma Bhushan. Shasha's passed at 1986. Now how many years? 40 years? So we crossed. Venous plasma glucose more than 10 milligram is the proved for GDM. And again, Lois Javanaki, she had come to Chennai in 2006. In her study also, she found fetal renal threshold 110. And again, Hernandez 211. What he said is, again he said, 2 ppg, again 110. And finally, NIH, National Institute of Health, 2018, again he came with 110. So you will appreciate from this, the 110 is now is what we started with Professor Hariharan, Professor Sundaram and all working with Venkatram and all working with us in the institute. From the time when we started, 1986, it has not changed. So, old is gold. What is it?
CGM also 110, sir.
Old is gold. That could nobody change it.
CGM, current CGM also 110, sir.
110, huh?
For GDM.
Yeah. So anyway, I am saying, because our team was so good, we are able to do this. At that time, in 1986, imagine, they are going to Institute of Obstetrics, either egos or astronomers, the number is not changed, continues to be there. So finally, Shasha's concept, prediction of GDM towards same thing, 2022. 1986, now it is again repeating 2022. So this is worth taking a slide. You can, any student, anybody here, you can show this. This 140, 110 is the important number with pregnancy. So finally, categorization of glycemic with pregnancy. GD we all know, glucose-based, 2 ppg more than 10 milligram, 140. Another thing is that gestational glucose intolerance. Again glucose-based more than 120. What this two is over. Now we call early gestational glucose intolerance. That is called EGI, 10th week, prandial based food. There is no glucose. Again, but here 210 milligram. And finally, normal glycemia will be 99 plus or minus 10 or less than 10. So these are the figures. Please count down. First two things are glucose. Last two things only meal plan. So what you have to keep, remember, you can take the photo of this. Prediction of GDM. 2 or ppbs more than 10 milligrams at 10th week. That is the first message. Second message, preventive action has to be taken at the 8th week so that metabolic glucose remains less than 10 milligrams throughout pregnancy. Second point. Third point, intervention, medical therapy, metformin, if physician tells is okay, to continue until confinement, and follow-up essential out delivery. This is the message, final message of to be taken in due course. So, aim to maintain mental plus for glucose. I told you what message here from consumption to confinement. This should be always 2 hour pp blood sugar 99 plus or to the 109, that's 110. And here monitoring 2 hour ppg must go on 8th and green point. Monitoring till 8th and 10th week. 12th week, no point. I told you, whatever you do, after that, she will develop GDM only. No point working in there. So, antenatal woman likely to visit clinic regularly 8th and 10th. After that, don't bother. Once you are able to maintain 110, she will never become GDM. Never, never, never. When she doesn't become GDM, a child will not become diabetes. So all those things what you are taking are this simple thing, glucose, metal glucose, 110, that means no drug is necessary, no drug is necessary. See, the child will not become diabetes. Not necessary metformin. To check GDM, but deep sea, that you can do it. So finally, sequence of events in weeks. 10th week, prediction of GDM. 8th week, screening in anticipation. You must do it earlier, screening in anticipation. And then 11th week, fetal beta cell insulin secretion starts. Once it starts, one story I will tell you. Suppose 11th week, the blood sugar is high, what will happen? Mother and kid and the baby inside fetus. The moment it crosses 11th and 10, good child inside the mother, inside the womb, that child will produce insulin because blood sugar has gone up. So once it starts, it will not come down. So that means it's already known. That's why I told you, Professor Boston, hyperglycemia, hyperinsulinemia. Same thing here. 11th week, fetal beta cell insulin secretion starts. It will never come down. So 12th week treatment is not. There's 4 numbers. This is called sequence of events in weeks. Every week, 10th, 8th, 11th, 4th, 12th week, all of them have got a point for that. So finally, diabetes, now coming to the point here, diabetes-free generations. For diabetes-free generations, 2 hour personal blood sugar should be maintained less than 10 milligrams. The number should not be forgotten. Preconception, you see your daughter, happy she is. When she is found, she is also happy looking at her baby inside, pregnancy. And she is again goes here, postpartum. So all these things are within the range because of the, fortunately you are able to maintain the blood sugar level 110 and above. So pre-pregnancy, pregnancy and after postpartum. So that the title was given, remember I told you about the decoding GDM. Decoding GDM is here, early gestation diabetes mellitus should go to early gestation glucose syndrome. That's called EGI. I don't want EGDM. See, this reason is, if somebody asks, what is your mother, what happened to your mother? She's GDM now. What will happen? She'll feel GDM means diabetes. So both the pregnant lady and mother also will get upset. It happens in North India, if it tells GDM, they may send them out, oh, you have become diabetic. So EGDM should be avoided. You can call early gestation glucose tolerance, but it should be done by 10th week. And finally, so GDM versus EGI, what happens here? Early gestational diabetes mellitus. All of us know. And the book will know. It's wrong. Versus what we are suggesting will be the early gestational glucose tolerance should be told here because early gestational diabetes is the red. Early gestational diabetes mellitus, EGDM, has psychological impact on women and family. Therefore, hence we suggest a new term, that is what you are doing here, EGI, early gestational glucose intolerance. There is no word of diabetes, no word. So what is the mother, what happened to your daughter, ma? EGI. She doesn't know what is that. So if she says GDM, that's the problem. So hence we suggest a new term, EGI. So this is also published now. It's not, I'm telling you, this 2022 I published and proved everything now. So hence, hyperglycemic pregnancy is urgent. and then important to screen. And if you do that, simple, one test, 2 hour postprandial, one value, 110 of blood glucose. That is mantra, value, Om. Om is here. So friends, by prioritizing women's health and implementing evidence-based strategies for GDM prevention and management, we can pave the way for a brighter and healthier future is possible. That is what we wrote a chapter now. Hope and scope for diabetes for the generation. By 2047, this country should avoid diabetes. This is possible if you listen what I told you now. 100th year now of independence, 1947, 247, probably almost, I hope, this country will not have diabetes. Thank you very much. Thank you very much.
What energy, what concept. Great, sir.
You know, I never saw my wife. I was in the army. My mother said, you are going to marry this lady. I came and married like that. Okay, thank you very much. Thank you very much. Thank you very much. Thank you.